Sir, please, we are all waiting for you.
Yes, good evening and good morning from Mount Sinai very early. And we have been watching the case and clearly we thank our organizers of CSI and NIC this midterm meet with particularly Pratap Kumar to make this happen. Very early, we had a live symposium yesterday with the 10 cases and we came there early because I always want to teach and show the showcase. And with that note, myself, Dr. Kini, my left side, and Dr. Tu and Ali, our fellow, and the rest of the cath lab staff, which will have a little interaction. Knowing that we are limited time, because I have my second part of the meeting today, which I did request to Dr. Pratap Kumar that we have window from 4:30 to 5 o'clock for your time. But anyway, let's go to this case very quickly. We want to show, this is the case number 8 of your NIC meet. 90-year-old patient presented with non-STEMI a few weeks ago, has a left main and 3 vessel disease, good medical therapy. Patient actually was okay before that. At age of 90, he didn't have much trouble, but then has a complex disease with a near normal LV function, the high syntax score of 41, and of course had a discussion. And after the discussion, of course, both surgeon and family decided not to proceed with the surgery, even with the complexity. So we did RCA PCI, and today we are ready for the left main bifurcation, which we are going to show. So we have done all hard team, syntax, STS of 28 now, residual syntax score because RCA 2 lesions have been done, and the score is 4.1. And with that note, appropriateness point of view, this case will make it because of the hard team discussion now. And so Anu is ready to show. We can go back to the angiogram.
We can go back to the angiogram and show us with the 5 views like you just showed. Okay, good. So if you can see, this is LV function. EDP was normal LV function. The right coronary artery prior stent looks patent. Moderate disease in the distal RCA into the PDA. So this is where we are with the left side.
Show angiogram on the main screen right now. Don't show any OCT or anything hemodynamic. Yeah.
Okay,
you want to
good.
show.
So this is where we are. You can see
the calcium.
But the best view is this one. Heavily calcified. Angiographically, you can see tram track calcium. There is a stent in the LAD. But if you just take distal left main, which is a bifurcation 111, significant disease before the LAD and circumflex bifurcation, 95% in the circumflex as well as 90% in the LAD. This is where the cranial view is. The prox LAD stent is patent, which they have stented across a large diagonal.
Yeah,
so
that was a BMS stent 20 years ago. Since then, she has been fine. And this is the whole case with the angulated, as you can see there, angulated circumflex with a distal calcific nodule. Look, calcium, severely calcified. So with that note, I know that we are time constraint. So we went with a rota wire directly and did a 2O bar. And we'll show you the 2O bar here. We have seen.
2 bar in with a, what is the catheter size? 7.
Yeah, it's a 7 French.
7 French.
7 French. Yeah, 7 French with a 2O. 6 French can take 1.75. So we have done that. You can see.
Yeah.
And then we did the
wiring of the
OCT.
Then we did the
at this point.
We wired the LAD with our regular workhorse wire, which is run through, and then you take out. So side by side wiring, you remove the rota wire, and then also we wired the circumflex, and wiring of the circumflex was the fielder wire, which is polymer jacketed hydrophilic coating wire, and this is where we are. The OCT can be shown right now. Let the OCT run.
Show the OCT, please.
OCT.
Main screen.
Yeah.
Yeah.
I start from the mid LED. I can see the old stent, and before the stent, I can see the 360 calcium. I stop here, like here.
Yeah, right there.
Yeah, and I can see this is after the 2O loader, like deeply shaped by the loader, and go to more proximal. This is at the level of the left main bifurcation. Still here, a lot of huge 360 calcium at the left main bifurcation.
So, Dr. Pratap, I know Dr. Who else is there? Shukla and
Dr. Anil Dal is there. Dr.
Anil Dal.
Kalra is there. Dr.
Oh, good.
Prakash Rao is there.
And Sudhir are beautiful. You can confirm that, right? A severe circular calcium, 360 degree with multiple cuts. But there is no true calcific nodule. Kiski is our the imaging expert in the cath lab, and
deep calcium.
It's a deep calcium, both superficial and deep, thick rim of calcium. more than 0.5 millimeter. But more importantly, there's a circular calcium, and we have modified this with the 2.5.
No, so this is
yeah.
a 3.5 Wolverine into the left main. So you see there?
There's
You
still a
still
dent.
see that a
You can
little
see.
dent is still there.
Actually,
Yeah.
this
So we
situation,
went
will you-
twice.
will
We
you
went
try to
twice.
take an IVL or not?
Good.
Yeah,
We'll come back to that. Yes,
If
absolutely. We
let's,
heard you.
Let's finish. Yeah.
Yeah.
So this is the Wolverine there. We went up to 18 atmosphere. You still see it is not completely expanded. So that is very important for us to know that at this stage we have. This is for the side branch. We went with a 2.5 Wolverine again. Nice expansion of the ostium. So that is why, going back to your question, for the left main, when we already have seen that it's deep calcium, this is the case where you should consider IVL, and that's what we have. And the size of the left main, LAD is 3.5, but the left main, just at the bifurcation where there is heavy calcium, is about 4.0. We have a 4.0 IVL that we are going up with.
And
now
that-
this is one cautious time, that because it's left main and we are going to leave this balloon for a longer time, risk of ischemia is there. I know she has normal LV function. We are all ready here. Give some
Going to 4. And
Neo?
they're showing
Yeah.
the hemodynamics. Yeah.
and guide is out. Yeah.
Cross with the Wolverine into the circosteum. But
We
do
did.
you consider doing a rotational atherectomy to the circosteum as well
Yeah.
before
Well, I mean-
taking the Wolverine down? Suppose the Wolverine had not gone down. Moreover, when you see the angiogram,
Very
you
good
see
point.
the more calcium in the LOD, circumflex ostium than the LAD.
Yeah. No, the question is very important.
Go high.
Yeah. So
6.
question is very important that you go to the circumflex. Always, I would say
Good.
these are angulated. They get into trouble if you cannot have Wolverine go. Then only you will do the atherectomy in that case. But then we'll use a very small bar, 1.5 and so. The 4 atmosphere of the IVL, come back and look at this. Still there is a dent on the IVL.
Quick.
So we have 2 pulses.
So you
we are
should
going to do
start
more.
having ischemic changes. Quick.
Yeah.
Either you
Yeah.
do it or
one
you
more,
remove
one
it.
more.
Yeah.
We're doing it.
No, look at the
Yeah, no,
EKG.
but remember the part of that is the pacing which we see during,
no,
okay,
pacer.
again,
See the shock topics here.
yeah,
Don't-
yeah.
I think
That's
it
normal,
probably
yeah.
did open now.
So yes, therefore since the Wolverine went very easily, we did not do the atherectomy, and you see that really if you see the calcium is in the distal, keep it here, you want to see if you want to go back again, because the calcium is more into the left main to the LAD, and yes, you can do atherectomy, but a little higher chance of gutter and perforation. So therefore see that calcium is all into the
I think it
left
looks
main
good
to
now.
the LAD. Yeah, looks good. Yeah, it's
In fact, from
agree
here
that
we
angiographically. Yeah.
challenge to wire the circumflex as well. But I think your rotational atherectomy from left main to LAD modified that bit of calcium and
Yep.
permitted your wire to go in easily into the angulated circumflex.
Absolutely correct. Yes. So this is where many times people are concerned. Leave it there in case we need it, because we are going to now ready. As we have done the stents, we are ready to put a stent in the. We actually have our Zions Sky Point. We did already.
Oh, no.
Yeah, we'll
OCT
take a
or-
picture.
But
One
do
more
you think
picture.
that
Yeah.
the circumflex ostium is
City.
adequately prepared as yet?
Yes,
Yeah. What is this?
that is
What
for
the
sure.
plan? Actually, you should single
We are
stent
going to
strategy.
do
That's what
our
you gave me
2-stent
510.
strategy.
Why did you give me that?
So the reason for 2-stent strategy, if you see here,
Right.
this
You
is
have to
very
do this one.
important compared to what I showed with the left main, where we knew that you saw a little
Dent.
a dumbbell. Yeah.
Okay.
So
So now we are going with the 2.75 for 12. Is
no 2.5 or 2.75. Yeah,
2.75.
2.75 12
12
into the circumflex.
The Zions Sky Point. I know we have little earlier generation our Zions stents in India, but I'm sure more and more newer generation Alpine is, I think, may have started already or coming. And basically it is the available. Yeah. So based.
Alpine is here. Sierra
Oh, good.
will come.
Beautiful.
Sky Point also will come.
Yeah, exactly. So knowing that basically it's the delivery, the stent material, the stent drug, the polymer all remain the same as the original Zions. It's all the delivery catheter, and so yeah. See, this is the stent. This is the 2.75, and now we are going to put a 3.5 18 Zions.
3.5 or 4.0? 4.0.
4.0.
Yeah.
Yeah, sorry, 4.0. 4.0 in the LAD. So 2.75 in the side branch
And we are going to do a mini crush. I know that in India, everybody
You
loves also
did not-
DK crush.
You did not
Yeah.
want to image the circosteum before putting this stent.
No, but question is, what will it tell us? Tell me, angiographically looks
The
good.
maximum
Yeah.
restenosis we would expect would be at the circosteum.
Understood. But point is,
The angle
imaging at this time.
expansion-
No, but imaging at this time will tell us what?
We already showed you angiographically
Yeah.
how it, so you could see the full
So
expansion.
while you get your strategy ready, we just got
right
to
there.
take 1 minute and go across
Yeah,
to.
we are ready
No,
right
no,
now.
no, we are ready here.
Yeah,
We
yeah.
are ready here.
Yeah, go to the side branch.
Yeah.
Yeah, go. You need to take a picture, we are okay.
Because after this will be done. Yeah.
Yeah, yeah, here.
No, Dr. Kinney, you're telling that imaging is not required for circumflex imaging, then why imaging is required for LED? And if
No,
you
no, no.
have everything.
No, no, we only for the
Because-
left main to LED we
Yeah.
did. Remember left main to LED when we did the balloon?
Yeah.
We clearly showed we are not happy
Yeah.
with the way the expansion was.
Right.
So we
That's
have to
the
make a decision. Is it the case that we want to go with IVL or no?
Yeah.
So we did see the
But
deep
data
calcium.
tell-
Yeah.
But the data telling that whenever you do imaging, if you do imaging from the both circumflex and LED, will give a much better understanding than the single vessel imaging.
No, I mean, the theoretical point definitely there, we are taking the wire out now. So question comes is always, to me, I think the biggest thing is that you need to do it in the end. As you mentioned, the ostium of the circumflex is always a trouble and you want to have a good stent expansion. So yes, I would say that any point where we had that if the balloon had not expanded,
Go.
then we definitely would have go with the imaging, try to see whether maybe we need to do IVL into the ostial circ also. But would it be a different one?
2.5. So this is now 4018
At 16 atmosphere,
4 oh my God.
huh? And we approximately,
No, LED is not 4
okay,
oh.
so 12
Down.
atmosphere, good. And we'll have a 4.5 balloon.
This is now the IVL balloon used, right?
Yeah,
No, no,
IVL,
no,
we
no.
use IVL before, 40 here.
This is the
Now
stent. We
this
are
is
already
now
doing the mini
stent.
crush stent.
Stent
Yeah.
already
take
placed. And
Yeah.
you
Stent
have
is
to
already
do-
placed.
Yeah,
Now you have to recross to the circumflex
yeah,
or you are
of
not?
course, right
Yeah,
there.
we are
Yeah.
going to recross. We will recross, spot, kiss, and done.
So
Yeah.
what we'll do is, if you want to go to complete the case other side, fine. And we are just going to do it and we'll just show
Yes,
you in next
just
5
we will
minutes.
Go
Yeah.
to the final shot to see
Yeah.
the last
Yeah.
scale, other lab and
Beautiful.
come back.
Beautiful.
Dr. Very good demonstration
Great
and we'll come back
demonstrations.
to you, sir.
Yeah.
Dr. Column, please, Column. can you-
Fastest calcific left main bifurcation. Remember, it was really great tribute to your skills.
It was actually wonderfully demonstrated how to deal with these things, you know. So can you go to Dr. Column? Can you just show the final shot and describe how you
shot.
did the last?
Okay, so could we just play the final shot, please? Hi, welcome back to Belfast. Gareth, could we just play the final shot, please?
Is that you are not doing this bullshit?
That's it, one before that, please. So
I told you
essentially,
that.
we put a 3.548 using a guideliner support and a 4.032 Synergy Megatron and post-dilated with a 4.0145. And you see we've got a very acceptable stent result from what was a diffusely diseased vessel with a combination of nodular and concentric calcification. And we will show you our IVUS picture, but we have the smallest stent area we have is around 6.8 millimeters squared. There is an area of constraint due to very significant nodular calcification where the area is around 6 and at the top end we're around 9. So we're very happy. We've got fairly uniform stent expansion. We have got an area of relatively normal vessel beyond the distal stent, and the patient is now off the table without any complications.
It's an
So-
unbelievable result. It's
Congratulations.
It's very,
Great result.
very pleasant to the eye, and congratulations for a great job.
Not only
Yeah, that's
that,
all that
you
matters.
demonstrated with the IVUS, it is an excellent result throughout. And actually, we should tell that the first angiogram and the last result, unbelievable. And you could expand the vessel very well. What do you think, Sanjog?
Yeah, this looks like a great result. Congratulations. Okay.
Any comment from Surya or Rako Sharma or anybody or Anand Shukla? Any comment?
Excellent result. The first angiography shows the heavy calcific. So we expect that we require the good support and the plaque modification. At the end of the day, you acquire the good result with the plaque modification. Excellent one. Thank you.
Yeah, but
Yeah,
what
well, hopefully
happened to
they'll-
that nodular calcium at the first bend of the RCA? Because
So
that's where-
we think we possibly shaved a bit off that and ultimately permitted us to push it out of the way without creating a sunroof.
Yeah, I think it was debulked with the rota, so I think
So
atherectomy.
you put a stent only in the distal, mid to distal LED, not in the proximal angulated
Oh
part.
no, the whole area is stented from the
All
distal
areas
part right
stented.
back to the, yeah. And you can see there's excellent stent expansion. So we have managed to both modify circumferential and nodular
But
calcium.
I think the learning points we were trying to get across is just sometimes you have to use all the calcium modification, equipment
All
at your
devices,
disposal.
all devices
You know,
to be used.
Yeah, absolutely.
And the
So the
most
quality of
expensive
PCI has
than-
gone up, but it takes a bit longer.
Yeah, column and actually Andrew, we should
just
tell that it is more
one
expensive
word.
than CTO now.
Suppose there is a difficulty in
Okay.
exchange to a rota wire. What is the option?
We do, in terms of upfront,
Yeah, if it's difficult to exchange, you're talking about free wiring from the outset, which I think in this lesion you probably could have free wired. I mean,
Laser, maybe a laser.
there was a bit of difficult. But
oh yeah, you could use laser. We don't have it.
yeah, we don't have it. So
Laser-
laser, you're absolutely right.
laser
Laser
would
is a good
do-
option.
Laser would do very little here. Having done a fair amount of it, this is nodular calcium. This is a rotablation case or an orbital.
I think it's knowing your equipment. The Mamba Flex
Will laser will
135
help us?
centimeter
I don't think-
microcatheter is a good microcatheter to exchange. I'd recommend that. The Mamba Flex goes where other microcatheters don't.
No, sometimes even microcatheter exchange is not possible. Then you have to take a dock
So,
extension
I-
and take the wire down. And
I would say in the percentage of cases where a standard workhorse wire or a jacketed wire can't get down, such as a fighter, but you can't advance, I would typically use a combination of very small balloons to get the microcatheter down. And if that doesn't work, in the end, you've got your free wiring option, which usually gets you out of Dodge.
And support, and support as we talked about, changing your guide, putting a guide liner down, if it's just about crossing, adding support. But knowing your equipment, someone
Thank you,
mentioned at the beginning, is important.
Thank you, Colum and Andrew. It was a wonderful demonstration and we enjoyed it. And we are telling you a thank you from the NIC India.
Great.
Thank you very much.
Thank you for having us.
Grateful to be asked. Thanks, guys. Have a wonderful conference.
Thank you. We will go to Dr. Samin Sharma, please.
Down.
Sir, are you ready
First
with
of
the?
all, you're not
we are ready.
done.
thing?
Yep, we are all ready and just going to
no
show
pressure.
step by step now.
Good. Yes.
The 6 atmosphere. You go a little more.
Nice enough. Okay. That's our final case. Okay, down.
Good. Okay, so let me tell you where we are.
Let me do it.
Sorry.
Okay, please.
No, take it out. Take this out and then we'll show. Yep. Good. And ready for the iOS?
Yeah, take a picture.
Yeah, let's take a picture. Okay, 1 second. We'll come back to you, Pratap. Good.
Okay, good.
Okay, good.
Yes, sir.
Sure now.
So
Yeah.
after we left you, this is where our angiogram was. So we used the same fielder wire and recrossed into the circ. After we recrossed into the circ, 275 high pressure balloon into the circ, and this is a very important thing that in non-left main, a non-compliant balloon can go through the stent strut. Okay, so we able to do that. Before that, then we did the pot of the left main. That was with the 4O. So went with 4O up to 18, and then we did this final kiss here. That's where we are. And now I think you saw the final result. We're ready
Beautiful.
for the imaging now.
And this is the one where we'll definitely will do the OCT of the side branch also to optimize further. Because we know that the ostium of the circumflex is always the Achilles heel of
Are you going
restenosis.
to do
We
a
want to
final
get.
pot to the left main?
No.
Well, I mean, the question always comes that you have done the pot, you have done the case, do you do the repot or so? We are doing the imaging and let's see how things are. If you think stent is not opposed or not, didn't get a lumen of 8.59 millimeter, we probably will go back with a 4.5 balloon because vessel is just about 4.4. This 90-plus-year-old, we'd want to be just not way too aggressive
Just a
and
little
create problems.
concerned
Actually,
because
you
of the.
always have an opinion that there is no pot required in the final, right?
Well, I mean,
We are always of the opinion that you need pot in the left main,
Yes.
non-left main. We are not a believer of pot.
right.
There are two trials. Actually, ProPot is a trial that is going to support that, which was just published. Actually, OCT showed when you did pot, there were more unopposed strut than compared to just final KBI.
Good.
Yeah.
So yeah, point is that do you do a repot? That's the whole question. We believe in
That's
pot.
the
We did it.
question.
Yeah, we did the pot.
So we are not a
Repot.
believer of repot because you had done a pot, you did a kissing. I think that's good
not
enough.
Not good clearance.
Okay.
Okay, and we'll show you the eye of both OCT of the SIR as well as of the left main and whatever need to be done. I know you have time constraint to advance the wire of the SIR a little bit.
Yeah, great
We
clearance.
have time constraint. Okay, ready?
Yeah, ready. Yeah, great image.
Okay.
Okay.
Excellent result.
I'm checking.
Yeah.
Okay, now go at the level of the left main. We
Sure.
want to see how the stent
See the
expansion is. Yeah.
bifurcation? Looks
Yeah.
Very
expanded.
nicely
Yeah, looks
expanded.
perfect.
Yeah.
So I'll show you
Good,
the
right?
proximal edge of the stent,
Yeah.
left main stent.
Just show.
Yeah, this is
where
a,
the point of
proximal
interest.
edge. Yeah, perfect. No malapposition
Yeah, nice.
and a no edge dissection. Yeah, proximal left main edge. Perfect.
Yes.
Yeah, and we just want to emphasize the point of the pot and repot and all this. You know, these are all being done gut feeling. There is no randomized trial. Only pro pot, the randomized, we didn't support it. We actually have our data on the endothelial shear stress of the pot and the kissing balloon dilatation. And we found actually that the kissing balloon dilatation gives you good lumen and less malapposition. And this is same pro pot showed. P-value was 0.12, but at least the trend towards that kissing balloon dilatation is plus minus pot is very good for non-left main. Now, left mains are different. So in this particular case, as we have said, that we have done it, we want to have a lumen of 8.5. It is already 11 plus for the left
11.5,
main, and
yeah.
proximal LED is how much? And
Proximal
LED,
LED.
proximal LED
Are
has to
you
be more
not
than...
concerned about
Yeah.
the cylindricity of the
It's like
distal
lying.
left main, because it was a very calcific distal
Yeah.
left main?
Yeah. So that's a very good point. Eccentricity index, there have been some studies showing association with the restenosis, but question is what else can you do? Getting too crazy, as I always say, that
No, there is
you
a
may
little
end
bit
up in
of
price.
limited expansion of the stent when you have
Yeah.
a calcium
Yeah.
abutting into the lumen.
Yeah.
That is true. But
Yeah.
I'm just telling, sir, one point I just wanted
Yeah.
to tell you.
Yes.
Usually the European bifurcation club tell that
Yeah.
the DK crush is actually a study by Chinese. That is why we don't have a comparative data from the European. That is the same thing we are applying for the port
Compress on
also. I
coin.
don't know whether it's acceptable or not.
Yeah, and I'm so, like EBC, main and particularly when they tried to do, they did all culotte. They didn't test this whole concept of the DK crush out of China. And I'm very disappointed with the EBC one trial. EBC main, I mean, clearly we needed that answer that really DK crush is really superior. Because I can tell you, we do about 35 to 40 unprotected left main every month, and 95% of them are we do a mini crush. The DK crush rare case where we do a radial, or we will do a and we never do. I mean, not never, maybe a 1% culotte, but all are the mini crush with excellent angiographic short and long term results. So now OCT catheter is not going through it. What we want to do?
Nothing. Leave it alone. Angiographically looks good.
Yeah, so let's take a picture again. So question is how much you push. OCT catheter didn't make it.
So actually, if the OCT catheter does not make, you have to take a device to do actually a kissing balloon inflation again, and then keep the lumen opened up, and then do an OCT again and show us that OCT, the vessel is well opened up and all.
Okay,
now,
yeah, go back to the angiogram.
see here.
I mean, you
Yeah, no,
cannot.
but I think we can open the ostium of the circ with a bigger balloon. That is reasonable. You had a 2.75.
Even angiographically, the circ
That's still narrow.
ostium
No,
is-
the
Ostium.
OCT catheter is not going
Yeah.
because the way the amount of calcium is and the way the angle is of the circumflex.
Yeah.
We will dilate it.
Yeah, we'll dilate.
Yeah.
But yeah, you're right. We do see little ostial. See, there is because we need to get there 5.5. But I would say in this particular case, our main goal was let's open the left main, and her age, 90 plus.
And also you have to be very cautious when we already have placed the stent. Now we are trying to get this device and get crazy so that we want to go and do imaging that can cause LSD,
Yeah.
deformation of the stents. Everything looks very good here angiographically now. And we have done the OCT of the left main to LED. We see a good stent expansion in the left
In
main.
an academic program, we are actually telling how to do properly. Actually, you can get away with these things usually. There is no problem. Mini crush may be a better technique for you and in the expert hands. But in the teaching session, actually, we should tell which is the best technique for the people to listen and to understand. That is
No,
what
but that is
our
true. My friend, we are talking about academic program, except the DK crush. To after China, any other trial which has shown there are enough registry data that even culotte and mini crush gives you enough results, good results. So we are talking about academic programs
Down.
and academic teaching, my friend. We do a CCC live with 18,000 viewers every month in 175 countries.
Wow.
So academics, yes, but academics has to be understandable, not with a personal opinion. What is in the literature, same pot, pro pot, all those are academics. That there is no data, we do many things, but they have to be supported by the trial data. And you tell me that which trial have shown,
You can use
No.
whatever strategy you want to use, as long as you finish with imaging both in the main vessel as well as the side branch. So
That point,
once
yes.
if you've done
We'll
that,
try
and
once
you've got
again,
good
yeah.
results,
Yeah.
we respect whatever strategy is chosen.
Yes, we will try now. Absolutely, very good point. So we are going to go back and do the OCT of the circle because LED left main very good. And now question is, we go back again. We have opened the ostium, see much better, and we are going to now do the one more try on the OCT. Let's see.
Actually, at 90 years,
Yeah.
achieving 99% result is very good, in my opinion. Putting more contrast.
Yeah,
more
sure,
contrast
sure.
to
I mean,
No. Actually, Surya, we just tell actually it is a very good result created by angiographically. Actually, that is what we also wanted. But we actually, for the discussion point of view, we have discussed. That is all.
Yes,
Nothing
yeah.
else.
I think as an academic center, we should also teach interventionalists when not to get crazy and
Yeah.
go behind something. And then you get into trouble.
Good. Let's see.
No,
Let's see. That's how it goes.
In which case we could have just used an IVUS or something so as to avoid the contrast burden.
We have the IVUS. We can do the IVUS. Yeah. We can do the IVUS if need to be.
No,
Yeah.
let's
see if it goes.
just
Get
finish
IVUS
it.
clear.
Yeah.
Okay. Okay. Let's see. Good. It went in.
It's not still not making the turn into the
It won't go
circle.
more than that.
Yeah.
Okay.
Wait.
All right.
Okay, sir.
Okay.
No.
Every-
Camera is in left main.
Good.
It's the angle that is.
I mentioned before starting, it's the angle, nothing to do with the balloon. You
Did it
saw
go
that?
back in?
No,
Yeah.
you need all the way down. So it's you have to go that way. See that?
But can we do half or no?
No, we are
Try.
in the ostial. No, we are in the ostial left main.
Yeah. Let's see.
It does not. You
How
will
much
not
it
see
goes. Yeah.
That's
The
it.
second
See
marker
that, that's the second marker is in the
Yeah.
ostium. That's
But
that's
the
where.
wire.
You're right.
Let's see advanced wire. Yeah.
So we can leave it actually.
We can leave it.
No,
You
no, one
can-
second.
If you would
Yeah.
like to optimize.
No,
with
no, I
IVUS
don't,
even
uh,
We have the
later.
IVUS then.
Yeah, we can do IVUS.
Get the IVUS.
Let's IVUS then.
Okay, so just to be complete, you are right, because there is a lot of tortuosity, same. Point is, we also taken everything consideration. It's a reasonable that OCT did not make a turn fine, but yes, we want to have some kind of imaging. So we are here with the IVUS and try to, our goal here is, we get 5.5+%, 5.5 millimeter lumen. Yeah, good. Let's go.
Okay.
Okay, we are ready with the IVUS. Let's show that IVUS on the main screen. Very good.
Yep.
But angiographically, reasonable results. Everybody agree
What
that?
reasonable?
Very
Excellent
good.
results.
We are all
Yeah.
delighted.
Not we are. Please.
Angiographically, very good result.
Yeah,
Excellent.
We want to see it is excellent or not. That's all.
yeah.
Angiographical is excellent. Come.
Yeah.
So we'll show it with the image.
Angiography is very good. Is it excellent? Imaging will tell us. Yeah.
Come closer.
Okay, good. We won't go more than that. Even this one won't go.
Yeah.
But we want ostium
that's
angio-
ostium.
Yeah.
Okay, I'll
That's
start
all you
pull back.
need.
Yeah.
Yeah,
This is
start
the-
pull
good.
back.
Yeah, it's coming. Yeah, looks expanded. It's coming. Now come to the bifurcation. Yeah,
Yeah.
looks open.
Good. That's all
Okay,
we
good.
need. Yeah.
Okay, and
Something.
give us a
Everything
cross
good.
section. Yes.
Very
Yeah,
good.
five.
So
Yeah.
now it's a
No, actually, it looks
bifurcation.
very good, ostium. See that now?
Yeah, perfect.
Yeah,
So
go
this
to
is
the ostium. Ostium
Wonderful
circumflex.
demonstration. Ostium
Yeah.
is well demonstrated.
Show it how much?
and shown that it is very
5.5.
nicely
How much it
opened
is?
just a minute.
Yeah, right there.
up. 7.2, 7.5.
Yeah, like 7.
6.9. All right. We are
Brilliant,
done with
brilliant,
this.
brilliant.
Fantastic, and thank you very much giving
Much
us
more.
opportunity
That-
and great
Thank you
discussion.
so much,
Thank
sir.
you.
Okay.
Thank you, Dr.
Bye bye.
Sharma and Annapurna.